So thank you for inviting me. It's a difficult task to do this. This is a great drug and a great opponent, and Dr. Chen really made his case very well. But let me try to point out some issues with Brentuximab and with this trial. So I have to make the argument that we should not routinely use this drug after transplant. Where does this come from? Why such a trial? These are our old data. This shows how long I have been doing this. Is from MD Anderson back in 2004 when we summarized the long-term data on autologous transplant, long-term survivals. This goes out to 12 years or so. And as you see, only 30–40% of those patients with autologous transplant were cured in those days. So quite disappointing, clearly a curative therapy for some patients with relapsed Hodgkin's disease, but only a minority. And then when this wonderful new drug comes out with great response rates, it makes sense to try to improve those response rates. And designing the trial, as already multiple times shown here, so I won't dwell on it. And then we see this great improvement in progression-free survival. And notice, in this trial, the control arm has approximately the same long-term outcome, although the curve doesn't go out as long as the one I showed you earlier, but it's about 50% in the control arm, and it's about improved by about 20% in the Brentuximab arm, so it makes a lot of sense. I will argue that does no longer make sense. It might have made sense back in 2004, around the time that this trial was designed. It might still have made sense, but in this day and age of augmented induction or augmented salvage regimens and use of PET scans, it makes much less sense. So I will make the argument that we should be careful about toxicity, and I will disagree somewhat with Dr. Chen. I will more importantly argue that it may not be so relevant anymore in this day and age, and that it may be in many patients futile to use this drug. Toxicity, first point. What is the toxicity of Brentuximab? It is a great drug. It is a wonderful drug, but it has a number of toxicities that are well reported, and some very common and some more uncommon. And this is what is generally reported. There is neuropathy, grade 3–4 peripheral neuropathy in 8–10%, and it can be severe. I've seen patients who suffer seriously from the neuropathy and who have chronic pain. There's also some neutropenia. We don't think of this as a myelosuppressive drug, but it is a drug with some neutropenia and with some thrombocytopenia. More rare, but definitely reported, and several cases. I put here 3 reported cases. There may be a couple more, but there are cases of progressive multifocal leukoencephalopathy that have been fatal, whether caused by Brentuximab or whether caused by Brentuximab given after multiple prior treatments in a severely immunocompromised host remains to be seen. But here we are talking about patients who would receive this in a setting of profound immune compromise after an autologous transplant and after salvage therapy. So we cannot ignore this. And lastly, there's there's pulmonary toxicity when given in combination with bleomycin, as somebody already mentioned. It's a concern. In transplant, we use a lot of BCNU. BCNU causes classically pulmonary toxicity. What is going to happen with pulmonary toxicity of our autologous transplant regimens when supplemented with Brentuximab after transplant? That was not well studied in this randomized study. And lastly, pancreatitis has been reported in blood last year in, I believe, 5 or 6 cases, and 2 of them were fatal. And it may well have to do with low-grade expression of CD30 in some patients in the pancreas. So what happened in the trial then? Same slide that Dr. Chen showed you, but look at grade 3 toxicity. Sensory neuropathy, 10% versus 1%. Motor neuropathy, 6% versus 1%. So motor neuropathy happens. Neutropenia, 29% versus 10% of grade 3 and more. 33% of the patients discontinued the Brentuximab prior to completion. So minimal neuropathy, but sufficient to stop the treatment, so it cannot have been so minimal. Myelosuppression, 25% of these patients required use of Neupogen or filgrastim for support during the administration of Brentuximab. So it may well be that this drug given after autologous transplant, when the hematopoietic system is at its weakest, may be more difficult to tolerate than in other settings. Lastly, there are 2 deaths in the Brentuximab group, one from ARDS and one ominously from pancreatitis. So again, these are not isolated cases. This comes into a context of a drug that has some pulmonary toxicity and a drug that has some known pancreatic toxicity. So it is a great drug. It adds to progression-free survival, but it's not devoid of toxicity. I will argue that it's not really relevant. Why is it not really relevant anymore? Because this curve was generated long before we had PET scans, and Dr. Alison Moskowitz has just shown her data that in this day and age, with intensified induction, with ICE followed by GVD if necessary, or whatever regimen one chooses, one will get not 40% cure rates, but one will, in the majority of patients, get 80% cure rates. So are we still going to add 20% with the addition of Brentuximab vedotin after this? One wonders. Perhaps one should restrict the Brentuximab vedotin to these patients who remain PET positive prior to transplant. Brentuximab, as already argued, is commonly used prior to transplant. So where does it fit in here? And not too long ago, I saw a patient who had Brentuximab, didn't have a great response to Brentuximab up front or as initial salvage, then had ICE, went into a transplant, and then do you give Brentuximab vedotin as maintenance post-transplant? It's an unanswerable question, but the one that we answered by not giving it. And lastly, the drug did not improve long-term survival. So I would argue, in conclusion, that it adds toxicity, that it's less relevant in this day of age of PET scans, where we can really tailor therapy and improve efficacy of salvage regimens and autologous transplant by tailoring our salvage regimens, that we don't have improvement in overall survival. Given the expense, the potential toxicity of post-transplant Brentuximab, I would argue that should be reserved for patients with residual PET positivity prior to stem cell transplant, and that we have to continue to be cautious about using it routinely. With that, thank you very much.